Welcome to our comprehensive guide on breath sounds, auscultation, and charting. In this video, we'll explore the different types of breath sounds, how to properly listen to them, and the best practices for documenting your findings. Whether you're a healthcare student, a practicing clinician, or simply interested in understanding respiratory assessment, this guide will walk you through the essentials. We'll start by defining normal and abnormal breath sounds, then move on to the techniques and key points for effective auscultation. Let's begin our journey into the world of lung sounds and their clinical significance. Breath sounds are the noises produced by the movement of air through the respiratory tract during breathing. These sounds can be heard using a stethoscope placed on the chest or back. They provide valuable information about the condition of the lungs and airways. By listening carefully, clinicians can detect normal airflow, as well as signs of disease or obstruction. Understanding the different types of breath sounds is crucial for accurate assessment and diagnosis. In the following scenes, we'll break down the categories of breath sounds and what they indicate about lung health. Normal breath sounds are typically heard over healthy lung tissue. They are categorized into three main types: vesicular, bronchovesicular, and bronchial. Each type has distinct qualities, locations where they are best heard, and patterns during the respiratory cycle. Recognizing these normal sounds is the foundation for identifying abnormalities. Let's take a closer look at each type and their characteristics, so you can confidently distinguish them during your assessments. Vesicular breath sounds are soft and low-pitched, resembling the gentle rustling of leaves. They are the most common breath sounds and are best heard over most lung fields, especially the peripheral areas. These sounds are present during inspiration and the beginning of expiration, with no pause between the two phases. Recognizing vesicular sounds is essential, as they indicate normal airflow through the smaller airways and alveoli. Bronchovesicular breath sounds are a combination of vesicular and bronchial qualities. They have a moderate pitch and intensity and are typically heard over the main stem bronchi, especially in thin individuals. These sounds are present during both inspiration and expiration, without a pause between the phases. Identifying bronchovesicular sounds helps in differentiating normal from abnormal findings, particularly in the central lung regions. Bronchial breath sounds are harsh, hollow, and high-pitched. They are normally heard only over the trachea. Unlike vesicular and bronchovesicular sounds, bronchial sounds feature a distinct pause between inspiration and expiration. If bronchial sounds are heard in areas other than the trachea, it may indicate underlying lung pathology, such as consolidation. Recognizing the location and quality of bronchial sounds is key for accurate assessment. Abnormal breath sounds, also known as adventitious sounds, are heard over unhealthy regions of the lung. These sounds can indicate a variety of pathologies, either within the lung tissue or between the chest wall and lungs. Adventitious sounds are considered extra lung sounds and are not present in healthy individuals. Identifying these abnormal sounds is crucial for diagnosing respiratory conditions and guiding treatment. Crackles, also known as rales, are discontinuous, popping sounds heard during inspiration. They can be fine or coarse. Fine crackles are high-pitched and resemble the sound of Velcro being pulled apart, while coarse crackles are lower in pitch and may sound like bubbling. Crackles are often associated with conditions such as atelectasis, interstitial pulmonary fibrosis, and retained secretions. Sometimes, fine crackles may be heard in healthy individuals, especially after deep breaths. Wheezes, also called ronchi, are continuous musical sounds that can be high or low-pitched. High-pitched wheezes are often compared to the sound made when blowing into a bottle or flute. These sounds are usually heard during expiration, but can also occur during inspiration. Wheezes are commonly associated with bronchospasm, as seen in asthma, chronic obstructive pulmonary disease, and cardiogenic pulmonary edema. Low-pitched wheezes may indicate retained secretions in the larger airways. A pleural rub is an extrapulmonary sound that resembles leather rubbing together. It is typically heard at the end of inspiration and the beginning of expiration. Pleural rubs occur when the pleural surfaces become inflamed and rub against each other, often due to pleuritis or other inflammatory conditions. This sound is usually localized and can be a key finding in patients with pleural disease. Proper auscultation technique is essential for accurately identifying breath sounds. Always use a stethoscope and ensure the environment is quiet. Place the stethoscope directly on the patient's skin, never over clothing, to avoid muffled or misleading sounds. Move systematically across the chest, listening to both the front and back, as well as the sides. Compare symmetrical areas to detect any differences between the left and right lungs. Clear communication with the patient is vital during auscultation. Explain that you will be listening to their lungs with a stethoscope and ask them to take deep breaths in and out through their mouth. Let them know you will move the stethoscope to different locations on their chest and back. If they feel dizzy or uncomfortable, encourage them to let you know so you can pause and allow them to rest. This ensures both patient comfort and accurate assessment. When auscultating the anterior chest, there are 4 primary sites to assess. 2 are located lateral to the lower border of the manubrium, and 2 are superior and lateral to the lower end of the sternum. These points allow you to evaluate the upper and mid-lung fields anteriorly. Accurate placement of the stethoscope ensures you capture the full range of breath sounds in these regions. The lateral chest is auscultated at 2 sites on each side, located along the mid-axillary line at approximately the 4th to 5th rib. These points are crucial for evaluating the lower lung fields, especially the right middle lobe and lingula. Proper technique in these areas helps detect abnormalities that may not be heard from the front or back. For the posterior chest, there are 10 key auscultation points. 2 are above the midline of the scapula, 2 are lateral to the spine of the scapula at about the T3 level, and several more are located laterally and lower, down to the bases of the lungs near T10. This thorough approach ensures assessment of the upper, mid, and lower lung fields posteriorly. The sequence of auscultation is important for consistency and accuracy. Begin at the top of the chest and move downward, comparing symmetrical points on each side. This approach helps you detect subtle differences between the lungs. Always listen to a full respiratory cycle at each site before moving on to the next point. There are several best practices to follow during auscultation. Always auscultate low enough to hear over the bases of the lungs posteriorly. Listen throughout the entire respiratory cycle at each point. Allow the patient to rest after every 5 to 10 breaths to prevent fatigue. These steps help ensure accurate and comfortable assessments. Avoid common mistakes during auscultation. Do not listen through clothing, as it can distort sounds. Never auscultate over bony areas like the scapula or spine, and avoid listening too low over the kidneys. Also, make sure the stethoscope tubing does not rub against the patient, yourself, or furniture, as this can create distracting noises. Accurate charting of breath sounds is essential for clinical documentation. Record whether breath sounds are normal or abnormal, and specify the type and intensity. Note the location where each sound is heard and whether air entry is good or decreased. Clear and precise charting supports effective communication among healthcare providers and guides patient care. When charting normal breath sounds, you might write, "Normal breath sounds and air entry good throughout." This indicates that the sounds are as expected in all lung fields. If breath sounds are decreased, specify the location, such as decreased breath sounds over bases bilaterally. Detailed documentation helps track changes over time and supports clinical decision-making. For adventitious sounds, chart whether they are present, their pitch, the part of the respiratory cycle, and the location. For example, Fine end inspiratory crackles heard over lower lung fields bilaterally. This level of detail is important for monitoring disease progression and response to treatment. Extrapulmonary sounds, such as pleural rubs, should also be documented. Record where and when, in the respiratory cycle, the sound is heard. For example, end inspiratory pleural rub, heard over left lateral base. This information can be vital for diagnosing pleural disease and guiding further investigation. Adventitious sounds are extra lung sounds, not normally heard over healthy lung tissue. They include crackles, wheezes, and pleural rubs. Each type of adventitious sound is associated with specific lung pathologies, and their presence can provide important diagnostic clues. In the next scenes, we'll explore each type in more detail. Fine crackles are high-pitched, discontinuous sounds often heard at the end of inspiration. They are commonly associated with conditions like atelectasis and interstitial pulmonary fibrosis, but can also be present in healthy individuals after deep breaths. Recognizing fine crackles is important for early detection of restrictive lung diseases. Coarse crackles are lower in pitch and may sound like bubbling or gurgling. They are typically associated with retained secretions in the airways. These sounds are often heard in conditions such as pneumonia or chronic bronchitis, where mucus accumulation is common. Identifying coarse crackles can help guide airway clearance strategies. High-pitched wheezes are continuous, musical sounds that often indicate bronchospasm. They are commonly heard in asthma, chronic obstructive pulmonary disease, and pulmonary edema. These sounds are usually more prominent during expiration. Recognizing high-pitched wheezes is key for identifying airway narrowing and obstruction. Low-pitched wheezes, sometimes called raunchy, are also continuous but have a deeper, snoring quality. They are often caused by retained secretions in the larger airways. These sounds may clear with coughing and are frequently heard in patients with bronchitis or during respiratory infections. Wheezes can be monophonic, meaning a single musical note, or polyphonic, involving multiple notes at different pitches. Monophonic wheezes suggest a localized obstruction, while polyphonic wheezes indicate widespread airway narrowing. Differentiating between these types can help pinpoint the underlying cause of the wheezing. Noting when a sound occurs during the respiratory cycle is crucial. Some sounds, like crackles, are more prominent during inspiration, while wheezes are often heard during expiration. Documenting the timing helps narrow down the possible causes and guides further evaluation. The location where a breath sound is heard provides important diagnostic information. For example, crackles at the lung bases may suggest heart failure or fibrosis, while wheezes in the upper airways could indicate asthma or obstruction. Always document the precise location to aid in diagnosis and treatment planning. The intensity and quality of breath sounds can change with disease. Decreased intensity may indicate poor air entry due to obstruction or effusion, while increased intensity can occur with consolidation. Describing the quality, such as harsh, soft, or hollow, adds further detail to your assessment. Common abbreviations in charting include ULs for upper lobes, LLs for lower lobes, RML for right middle lobe, and AE for air entry. Using standardized abbreviations ensures clear communication among healthcare providers and helps avoid confusion in patient records. If you detect decreased breath sounds, chart the location and extent. For example, decreased breath sounds over bases bilaterally. This indicates reduced airflow in both lower lung fields, which may be due to pleural effusion, atelectasis, or other causes. Clear documentation supports further investigation and management. For adventitious sounds, include the type, timing, and location. For example, fine end inspiratory crackles heard over lower lung fields bilaterally. This level of detail is essential for monitoring changes and guiding treatment decisions. When a pleural rub is heard, document its timing and location. For example, end inspiratory pleural rub, heard over left lateral base. This information can be crucial for diagnosing pleural inflammation and planning further tests or treatment. To summarize, normal breath sounds include vesicular, bronchovesicular, and bronchial types. Each has characteristic qualities, locations, and patterns during the respiratory cycle. Mastering the recognition of these sounds is the first step toward identifying abnormalities and providing high-quality patient care. Adventitious sounds, such as crackles, wheezes, and pleural rubs, are key indicators of underlying lung pathology. Their presence, timing, and location should always be documented in detail. Recognizing these sounds can lead to early diagnosis and improved patient outcomes. Always use a systematic approach. Listen over bare skin and compare both sides. Avoid common pitfalls like auscultating over clothing or bony areas. Allow the patient to rest as needed and document your findings clearly. These best practices ensure accurate assessment and patient comfort. Breath sounds provide critical information about lung health and disease. Early detection of abnormal sounds can prompt timely intervention and improve patient outcomes. Regular practice and careful listening are essential for developing expertise in respiratory assessment. Some common mistakes include listening through clothing, failing to compare both sides, and not documenting findings in detail. Avoiding these errors will help you provide more accurate assessments and better patient care. Always double-check your technique and documentation. To improve your auscultation skills, practice regularly, use a quiet environment, and focus on one breath sound at a time. Take notes on what you hear and compare with reference recordings if available. Over time, your ability to distinguish between normal and abnormal sounds will sharpen. Always prioritize patient comfort and safety during auscultation. Explain the procedure, check for any discomfort, and allow breaks as needed. This approach not only improves the quality of your assessment, but also builds trust with your patients. Let's review the key auscultation points: 4 anterior, 2 lateral, and 10 posterior sites. Systematically covering these areas ensures a thorough assessment of all lung fields. Remember to use anatomical landmarks to guide your stethoscope placement. In summary, mastering breath sound auscultation and charting is a vital skill for all healthcare providers. By understanding normal and abnormal sounds, using proper technique, and documenting findings clearly, you can make a significant impact on patient care. Keep practicing, stay attentive to detail, and continue building your clinical expertise. Thank you for joining us on this journey through breath sounds, auscultation, and charting. We hope this guide has enhanced your understanding and confidence in respiratory assessment. For further learning, explore additional resources, practice with real patients, and seek feedback from experienced clinicians. Your dedication to mastering these skills will benefit both you and your patients.